Section 4, we're going to talk about depression. Depression is a really common disorder. Each 12-month period, 6.6% of people will experience depression, and um, it's pretty common. And lifetime prevalence, that is, the chances someone will experience it at one point or another in their life, is 16%. And so you can see that this is essentially 16 times more prevalent than schizophrenia. It's just that schizophrenia, once you've got it, you have it usually forever, whereas depression can be more transient, where you have it for a few months and then you get better from it. It's twice as common in women as men, which is an interesting stat because it could also be that men's dysfunction just gets expressed in different ways, often through violence or drinking or something like that. And major depressive disorder causes significant impairment. And the age of onset distribution suggests that depression is prevalent over the entire lifespan. In particular, what's become more obvious in the last decade or so is people in nursing homes, old people in nursing homes, have a significant amount of depression, but it's not picked up because people think, oh, old people are just, dormant and they're just not that energetic. But in fact, it could be depression that can be successfully treated. In 2004, the World Health Organization spoke about the burden of disease in the entire world. And so burden of disease essentially means the level of impairment and distress that a problem causes. And so in 2004, the thing that caused the most burden of disease was lower respiratory infection. And on number 3 was unipolar depressive disorders. Unipolar just means a depressive disorder that is not bipolar. This is actually incredibly high. It's higher than things like HIV and AIDS. And the reason it's so high is that often people with depression get it pretty early in life and then suffer with it for so long. Burden of disease is different to like mortality rate. Like there are other things that kill lots of people, but if someone kills someone pretty, they get it one week and they get killed the next, it's actually not a huge burden of disease the way burden of disease is measured because it is, they die and so they're not carrying the burden anymore. Interestingly, it's predicted that in 2030, depression will be the disorder with the most burden of disease, with the most number of days missed as a result of days out of the year per head of population because of a depressive disorder. And this is because we're doing such a great job at fixing the other disorders, probably through biological treatments, but there are certain limitations of the treatments that we've got for depression currently. And some of the neurobiological correlates of depression include, dysfunction in many of the important brain areas, the dorsolateral prefrontal cortex, for example, just here, the ventrolateral prefrontal cortex, the medial prefrontal cortex, lots of frontal cortex things. And so some people think, all right, well, if there's a problem with the frontal cortex, all we got to do is fix the frontal cortex. And so people have tried things like TMS, transcranial stimulation, where an electric current is applied, a mild electric current is applied to the brain, to see if they can stimulate the dorsolateral prefrontal cortex, for example. And these things have shown some pretty good benefits. I would say, though, that also treatments like cognitive behavior therapy, a psychological treatment, is shown to improve the functioning of all of these areas. So for example, if you do 12 weeks of CBT, it's shown that your dorsolateral prefrontal cortex has a higher level of activation, and that area of the brain is important because it's engaged in the voluntary regulation of emotion. And that makes sense because CBT is about regulating emotion. Other findings show that if you do mindfulness meditation for 6 weeks, for 10 minutes a day, that your medial prefrontal cortex, the part of your brain right here, which is associated with paying attention and regulating attention, physically grows, it gets bigger. And that's also, doing mindfulness meditation is also associated with reduced relapse from depression. But moving on to more biological treatments of depression, there are a whole bunch of drugs on the market, heaps of drugs. Here are some of them here. And most people in the Australian context will, who go to their GP and get, say, hey, I'm depressed, most people will be offered antidepressant medication as well as psychological treatment. And the basics of the way antidepressants work, and in particular SSRIs, or selective serotonin reuptake inhibitors, is that it inhibits the reuptake of serotonin. So this is what happens without SSRI medication, in that we've got serotonin here, which then gets absorbed here in the postsynaptic membrane. But the problem is, in theory, is that there's not enough serotonin, so not all these receptors are getting activated. We know that serotonin is associated with feeling good, feeling satisfied. And it might be that too much of the serotonin is being absorbed back here. Whereas if we get serotonin, if we get tricyclic antidepressants or SSRI medications, it blocks the reuptake of the serotonin. And so the existing serotonin that we've already got in our brain stays there, more likely to activate the receptors in the postsynaptic membrane, and therefore we feel better. That's the basics of it. So it's not taking a SSRI is not putting more serotonin into our brain. It's just allowing the serotonin that our brain already has to be absorbed better and to be used with less waste. And in Australia, we are the second highest country in the world, only second to Iceland, in the use of antidepressants. And between 2000 and 2011, antidepressant medication doubled. And some people say that overprescribing is now a problem. And while antidepressants are really effective for severe depression, they're actually not particularly effective for mild and moderate depression, where we know that CBT and exercise is more effective. And in my practice, what I tend to do is, when someone sees me and they've got depression and they haven't been prescribed medication yet, what I tend to do is I tend to see them on 6 occasions. And after those 6 occasions, I give them, I tend to give them the depression anxiety stress scale at the start of those 6 sessions and then at the end. And if we haven't seen significant improvement, and if they are still severely depressed, I'll send them back to the GP with a letter, and the GP will prescribe medication. For some people, antidepressant medication is an absolute revelation. It helps them so much, and once they get on it, they think, oh my gosh, where have you been? For other people, it doesn't work so much, and there are some side effects for some people. But I think antidepressants are a seriously important tool that we've got in the toolbox. But looking at depression from a biopsychosocial perspective, and in particular, thinking about the biopsychosocial treatments for depression, we've got a whole bunch. The biological ones to start with physical exercise, we know, is a reasonably good treatment for depression. So reasonably good because there's mixed evidence of it. It's not very good in very severe depression, but and one of the big problems is you can't take exercise in pill form. And so the motivation to do exercise is a real problem because, you know, part of the symptoms of depression is a lack of motivation. And so saying, all right, just do exercise often isn't very effective. We know that improving food, improving the quality of food, reducing extremely high doses of sugar can have a very good effect on depression. Things like light therapy, particularly for seasonal affective disorder. Seasonal affective disorder is not a type of depression that tends to occur very much in Australia, but it does occur frequently in Nordic countries where in winter they've only got like 3 or 4 or 5 hour days. And in those countries, it's really common for in winter people to sit in front of light boxes that emit ultraviolet light as just a common way to help people not fall into seasonal affective disorder. For me, I find that my mood tends to go down a little bit in winter, not to the extent that I've got depression, but you know, so my treatment for that is going to Queensland every winter. Well, most years, not this year, for obvious reasons. But lots and lots of people report that in wintertime, because they get less vitamin D from the sun, less ultraviolet rays, and some interesting ways it interacts with our circadian rhythm, that in wintertime they feel sadder. And we've also, so all of these are sort of like natural ways that we can use biological mechanisms to treat depression. And so psychologists have a role in all of these. And then there's antidepressant medication and also brain stimulation. Brain stimulation can happen a number of ways. There's transcranial direct current stimulation, which is essentially sending a small current to your brain, and there's TMS. TMS, transcranial magnetic stimulation, and then there's transcranial direct current stimulation. I happen to have a direct current stimulation machine right here. If you can see me on the small video. This is something that I don't use clinically with my clients because the regulations around it are not very good. But essentially what you do is you get this thing and you stick it on your brain right here, or in your head, and it sends a small electric current through your brain that stimulates your dorsolateral prefrontal cortex, which is shown to reduce depression. This sort of research has been done for years and has shown, you know, mild to moderate impacts. The problem with this is that it's actually quite uncomfortable. It's like giving you this small electric current all the time. And frankly, when I've tried it on myself quite a lot, I don't really notice anything, and the discomfort I experience from it, I don't think is worth the, you know, any benefit that it gives. Some of the psychological treatments is cognitive behavior therapy. This is what I tend to do in my office with all the clients that I see. Mindfulness-based therapy and behavioral activation. And then also social treatments of promoting social connectedness. You know, there's been a lot of talk about the social isolation that people are currently experiencing, and then the mental health implications of that. And so we know that lots of the determinants of mental health are, well, there's a bit of genetics, there's a bit of psychological factors, but the social determinants of mental health are massive. And so in treating depression, if we can promote social connectedness and actually, you know, and I do this routinely in my practice, encouraging clients to reach out to their friends who they often isolate themselves from and sort of go into hibernation when they're depressed, can be very important. So that's the end of this one. I'll see you in the next.